Comprehensive geriatric assessment is really a misnomer. It's far more than an assessment. It's very comprehensive, but it also includes all the interventions that result from the assessments that you've done. So just to go through the components that are involved, first thing is taking a thorough history of the presenting complaint from the patient, and then it's looking at their past medical history. You often find that when the person presents initially, it's their immediate symptoms that they've had in the previous few days. But actually, that history can be ongoing for weeks or even months, developing into this acute episode that has caused them to come to hospital. So it's important to get the full background on that. Looking at a comprehensive cognitive assessment, and for that in Mullingar we use the 4AT. So from that we're able to determine if somebody has likely to have cognitive impairment or to have delirium. We get collateral for this, so if somebody has come in from a nursing home, or we know they have PHN services at home or home health, or they're living with family, we might try and get collateral from them to see if there has been any recent changes. From that then, if the 4AT scores 4 or more, indicating they have delirium, we flag that to the medical team that there is an emergency case with that patient, and to the nursing staff. And we'd refer it on to occupational therapy then if it's a new cognitive impairment, if they score between 1 and 3. And we also advise staff and family on how to communicate with the patient and what different things they can do to try and reduce the risk of delirium and try and get rid of it quicker. And we'd also advise someone who's very agitated that they require supervision, and we're able to do that at a very early stage. Then with vision and hearing, we look to see if the patient wears glasses, if their vision is corrected with the glasses, if they have hearing aids, if it's corrected with the hearing aids, and if there's communication issues, like you need to write for the patient, or if you need to approach them from one side of the bed so they can hear you, and identify that as well. From that then, if we know they wear glasses and hearing aids but they're in their bag, we take them out and make sure they have them on, and we get family to bring them in, and we advise staff about communication, and if we need to refer on to an optician or to discuss with the team about going to an ophthalmologist. We then move on to a swallow and speech assessment. So we use 3 quick screening tools, just any problems with their swallow when they eat or drink, any change in speech or language, or any voice changes that the family have noticed. We also find out if they're on a modified diet already, and if so, what grade are they on. From there then we refer onto the speech and language therapist. If there's any sign of aspiration, we refer on to a physiotherapist to do a respiratory assessment, and that intervention will often start in the emergency department as well. And then staff in ED, like nursing staff and MTAs, that would be advised about any modified diets that the patient needs to be on. And if there is signs of aspiration there, communicate it with the medical team as well. Following on from that, we look at a malnutrition screen. So we use the MST, which looks at weight loss and appetite. We also get the collateral from PHN's nursing homes and from their old medical records, because that's often where you'll find an old weight in it, and we take the weight in ED to compare. And we look at any nutritional support that they're already on. And from that then, if they score 2 or more, they're referred on to a dietitian. If they have nutritional support at home, they're advised to bring them in so we can maintain the nutritional status when they're in hospital, and team are advised again if there's a significant amount of weight loss.
Can I interject there? Just actually wondering about, it's obviously very broad. It covers like the role, I suppose, in terms of role clarity, who carries out all of these aspects. Is it one therapist and who's kind of crossover into maybe things to do with diet if you're a physio, or do you know, maybe to just explain to our listeners, obviously the composition of your fit teams across the different teams around the country is going to be different depending on resources.
Absolutely.
So maybe just to explain how maybe in Mullingar it works.
So in Mullingar, I'm the only person on the Frailty team at the moment. So as a physiotherapist, I do all of it, but I have very close links with our SLTs, dietitians, occupational therapists, PHNs and community, PHN liaison officers. So even though I'm the person completing the comprehensive geriatric assessments, this information is coming from a number of sources, and that information is invaluable. Some PHNs and home health supporting community therapists have been involved with patients for years, and they know them inside out like they're their own family member, and they provide an invaluable amount of information. So if I'm not getting the information from a patient for whatever reason, or from the family, it's often a therapist in the community that provides the objective information. Ideally, there would be more people on the team. There would be one member from each discipline and nursing staff, but when you don't have that, which I don't, it's just trying to gather the information in the best manner I can. And if I have any concerns, about somebody aspirating, I'd be straight on the phone to speech and language therapist to let them know that person is there. So we have very good links that way. Currently, I do all the geriatric assessments. Yeah.
But that's interesting to know, though, if there are teams or services out there listening, that you can do this without maybe having that fully compensated team. So it just, you know, you can start small and build.
Absolutely, and it's getting the right person in to do them, because you need a wide background, wide experience. So I have worked in respiratory before, in musculoskeletal, orthopedics, older person care.
That's a good point.
We're pulling in the information from all the different sectors, and from having worked with patients on the ward for a long time, I'm aware of what their needs are. I don't have the in-depth knowledge that all the other disciplines have, but it's to be able to screen, and that's what the CGA is. It's to screen so that you can flag to the right therapy who they need to be going to then at that point.
Yeah, great.
Yeah. So moving on to pharmacology, then we look at if there's 5 or more medicines included in the prescription, if there's any issues taking medication like crushing them, using a peg feed or an NG, or if there's any allergies documented on the Cardex, and just make sure if there's allergies in the transfer letters that they are documented on the Cardex as well. And we discuss it with a pharmacist, and we highlight to nurse and staff if there's any issues about taking medications, and again about their allergies. Regarding their ADLs, then we use a Barthel index, and we look at how they were before their acute onset of illness and how they are currently, if there's any aids and appliances at home, or if we think that they need some to be able to manage better at home. And we have a discussion about their home environment as well, if there are any trip hazards out that family can easily change. So we are in a position to be able to provide equipment in the emergency department, so we have some commodes, raised toilet seats, just some of the basics that can be provided if it allows for discharge home that day. If not, refer to the PHN for an assessment at home or the occupational therapist. And we're also able to advise nursing staff then as to what assistance they need to be able to give to a patient when they're getting washed and dressed in the morning or for transfers. And we can give advice to families so that they can start preparing the home for when the patient is going to be going home, if that's needed. Then we look at mobility, so we use the timed up and go, and we look at the previous and their current mobility and their transfers. Do they use the walking aid? Is that walking aid appropriate? When they're doing the timed up and go, we're looking at their gait and their safety awareness while they're doing it. Are they complaining of any dizziness or pain? And then we provide a mobility aid if required. We advise them about getting up, get dressed and moving while they're in hospital and even at home to try and maintain the mobility. If we think they're going to stay in, we advise family to bring in some day clothes and walking shoes so they're able to stay mobile on the ward. From a physio perspective, I'm able to give some musculoskeletal advice when they're there if there's any pain that's limiting mobility or weakness. And I'd refer on to physiotherapy then for further intervention if required. Then we look at falls history. So have they fallen in the last year? Is there a fear of falling? Is there any environmental risks that are contributing to this? And what footwear they're also wearing? A lot of patients do present with falls, and it's important to find out exactly what's happened coming up to this to see if they can identify the true cause of it. In Mullingar, we use orange bracelets to pop on patients' wrists so that we can identify to staff if they have any risk of falling, if they see them mobilising themselves. We give them a falls information booklet, which goes into information about pendant alarms, what to do if you fall. A lot of people have pendant alarms sitting at the end of the bed and they don't wear them, so it's important to emphasise they should be worn 24 hours a day and to actually press them if they are in trouble, because we want to try and prevent that long lie in future. We give more information about home environment. The staff are advised of the falls risk, and we refer to physiotherapy, occupational therapy, and we have an in-house falls prevention program, so they get referred to them as well. We then look at continence, so we look at elimination habits and any changes in these. Are they wearing continence wear, and is this adequate? Is it actually doing what it's supposed to be doing? We can provide a commode in ED if they're going straight home, or if not, they're referred to a public health nurse. We can refer for a continence assessment to a continence advisor or to a continence physio, depending on what the presentation is. We then look at sarcopenia, so we look at that maybe through reduced muscle bulk and through grip strength as well, using a hand dynamometer, and we can give exercise advice and nutrition advice when we assess for that. We also look at depression, loneliness and isolation, because that can affect a patient getting out, moving around, socialising with different people. So we advise social activities like going to day centres, retirement groups, and discussing perhaps a referral to psychiatry in later life could be discussed with their team. Tilda has done a lot of research to say patients stay interactive in the community and socialise, that they actually age better. So that's an important one to give information on. We look at skin integrity using the Waterloo scale, and we advise on a pressure relieving mattress for those people. We also look at patient and family preferences, and this is one of the most important things that you can look at, because if family and the patient wants to go home, that's where our target is going to be for them to go, and also about what interventions that they want in the future. This is discussed with the nursing staff and the team, so we know from day one what their hopes and goals are. And we also look at whether a DNA CPR form needs to be completed. And if the patient decides that they feel that they want to go to a nursing home, or the family feel that, we do look at whether a nursing home support scheme needs to be filled out, or in the future how they go about that if the time isn't right now but they feel it will be down the line. We look at carer stress and advising about support groups, home health, and just counselling and reassure that they're doing a good job. If there's any issues about safeguarding that come up, we contact HSE Safeguarding, SAGE, or the Gardaí. And then if any other concerns are raised by the patient or family member, we try and address them when we are there.
Sorry, Megan and Nolene, just wondering with respect to all of these components, is there an actual, for our listeners, is there an actual form, or can we, when we're uploading this, can we give them some resources in terms of templates that we could direct them to, that, you know, are there and are tested, that people could,
Well, we use it's a 2-page document, and it's very similar to what Kilkenny are using and Navan and Wexford are using. We complete it on a Surface Pro, so it's electronic.
Oh, great.
We do it online, and then once it's completed, it can be emailed to community services or to any other discipline with the patient's consent that they need follow-up for. So previously there was delays using the paper format. It was sometimes taking 7 days to get to the primary care centre that's a mile up the road. They have it in 5 minutes now with the geriatric assessment.
Great.
And they also use it in the primary care centre now as a referral. So instead of having to redo a referral form for them, they accept the CGA as a referral. So it's saving time and stopping duplication. And they're also able to prioritise the patients better because they have all the information and have the recent changes that have been there. But certainly I can give you a copy.
Yeah, that'd be fantastic. And just Ida O'Shaughnessy has a question here. So can she ask how you select your patients in ED? Do you see all patients that possess frailty markers as identified by a triage nurse?
So in an ideal world, we would see all of them. What happens in Mullingar is the triage nurse screens the patient using the BIP questionnaire. So if they score 2 or more yeses on that, they're flagged as being frail.
And maybe for our listeners, the BIP questionnaire is?
So the questions are, do you live alone? Do you need assistance to wash your dress? And can you leave your house on your own?
Okay, right.
And then
2 out of 3.
2 out of 3 yeses. And then I know that they're frail, so I get an alert. Now, because it's only me, I don't get to see everybody. I only get to see a small number, but that's how I pick them. And then they're prioritised. I might get information from the nurse or the doctors if there's a few people there as to who's most the priority for me to see.
Okay.
Yeah.
And then lastly, another one from Ida saying, do you send referrals direct to other disciplines from ED?
Yeah, so we have one HSCP referral form, so I complete all the referrals on that. So again, it's done at the front door. There's no delays in the referral. Because I'm a physio, I would do the physio intervention myself in ED if required. The FLTs will come down, and the others will be flagged. So I'd email to OT and to pharmacy, and then if it's seen as an urgency, they try and prioritise as well. And they're sent straight to community services via email as well. And we cover Longford and Westmeath, so it can be sent to any of the therapists there.
Great.
Follow on.
Okay, thanks.
Thank you. So when the comprehensive geriatric assessment, all the assessments and interventions have been completed, we then grade the patient on the clinical frailty scale. And this is really important because it's an internationally recognised tool, and it allows us to inform other staff. It's a common language, basically, inform other staff as to how complex the needs are for this patient. And then there's a huge amount of benefits from patients that they have fed back to us as well. So it's a comprehensive assessment of needs beyond what they just present with. So there can be a number of factors contributing, and we try to identify those. We do them as early as possible in the patient's journey. We refer to HSCPs early. The patient is mobilised early. We ensure timely communication of information between the hospital and community in both directions. We actually have a silver phone as well, so if community services know that one of the patients are coming in, they're able to phone in with some of the information that's on the CGA. We support patients' choice and their wishes, and it's important to identify this early in the journey as well. It's an inclusive approach with family, and it's really the aim is for the right treatment in the right place, at the right time, with the right person, rather, and it supports patients to choose home first during what's often their last 1,000 days, particularly if they come in and their clinical frailty scale is quite high. It's important that they're not kept in hospital longer than they need to if they need to be somewhere else for their care. The benefits for staff then, it shows a clear image of patients' needs before the staff member goes to see them. They know their safety needs are being addressed, particularly for discharge home. It aids planning and prevents discharge delays. There's more appropriate referrals to hospital and community staff. So the referrals have actually gone up. So there has been patients who are missing referrals to the disciplines, but now they've gone up and they feel that the referrals are appropriate. Unfortunately, that means they have extra people to see, but we're working on being able to cope with the extra numbers. There's improved communication and teamwork. As I said, the CGA is exceptional primary care, so this means that they're able to prioritise patients better. There's an early opportunity to identify and address future risks, like trying to prevent falls in the future, trying to prevent immobility, and just highlighting to the family and the patient how they can try and live well at home for longer. The SLT assessments are also coming in at the front door, which means it's less risk of aspiration for the patients, and it serves as an initial database reducing duplication and staff time. So there's benefits to the patients and to staff. By speeding up the staff assessment, it means that they actually get to spend more quality time with the patients as well. So rather than spending time doing a database, it's already done from the comprehensive geriatric assessment, so now the time is spent with the patient rather than on paperwork.
Sorry to interrupt again. We have two more questions which I think would be timely to answer, and I suppose if anyone else on the panel would like to answer any of them. So this is from Niall Redmond. Can the full scope of a CGA, as outlined on the slides, be undertaken as part of a single assessment, particularly in relation to the single assessment tool STAT that has been piloted to date?
From my understanding of it, some of the STAT would transfer straight into a CGA, but there's a number of other components that we would look at as well, that sometimes isn't addressed with the STAT. Also, it depends on when the STAT was last completed, so it's to try and get more up-to-date information as well.
Another question and follow on from that. On average, what time does it take to do a CGA?
It very much depends on the patient and their ability to communicate and how complex their needs are. It can vary from anything, and Danielle might say how long it takes her, but it can vary anything from 40 minutes up to 3 hours. The one time it took me 3 hours, it was extremely complex patients. They had an awful lot of needs, but we were able to actually get them home that day, and they stayed at home living well afterwards. Like, I followed up them for 2 months afterwards. So my 3 hours doing a comprehensive geriatric assessment, plus all the interventions that went with it, helped that person to go home, which was the right place for them. It was where they wanted to go. So that saved him being admitted to hospital unnecessarily and having delays.
I think as well the beauty of the CGA is that it is comprehensive. It includes a lot of significant areas in people's lives. And I think one of the things that are very important in it is that we ask people what matters to them. And that could mean that somebody comes in from a nursing home and has a very detailed plan in place, and it could take you 20, 25 minutes to complete it. Or somebody's coming in for the first time in hospital, in this hospital or in any hospital. They've had a number of weeks leading up to a crisis, and that then becomes very much more detailed with opposed to the perfect care plan for that person. And I think that's the beauty of this as well, is that every person that comes in is different. Every day we see something new, and every care plan that we put in place for every person is very personal. So it's very hard to put an average time on making something very personal.
Great. So the last question from Niall is, as part of the pharmacology assessment, is there a review undertaken of the type and amount of medication prescribed, i.e. with a view to identifying risks such as falls?
We have, Danielle has a pharmacist on board with the FIT team in Kilkenny. We have some support from the pharmacist at the moment, but unfortunately time is limited. So if I identify a risk, I would identify it to the pharmacist. At the moment, we don't have a thorough assessment. All we're looking at is 5 or more medications if there's any trouble taking them, and allergies. But if Danielle might.
Yeah, we have the same screening tool for polypharmacy. So if you're on Fibre Plus meds, you're automatically referred to pharmacy. Pharmacy then will pick up the referrals. We don't have a pharmacist on our team that will take everything straight away, so they kind of come maybe 12 to 24 hours later, and then do a med rec based on those. They do med recs now based on their own initiatives anyway at the front door, but what they try and do is prioritise the GEMS patients because they are at risk of frailty to do those first, and then they follow on with their own caseloads following that. And I suppose we very much highlight to them if somebody has had a fall, they will always pick up the CGA before they do their med rec to check what the person has come in with. Very often when we get fallers, we'll ask them if they've had any change in meds in the last 6 weeks, and very often that's the key factor in it. So I suppose it's highlighting those things. It's been a little bit more specific maybe on our plan for the pharmacist so that they know previous what they're looking for. Because med recs are very good, but they need to follow up on them, you know, and it just creates a lot of work for them.
And education is an important role as well. Our pharmacists go to an education session in the emergency department and flagging which medication puts patients more at risk of frailty and of falls and delirium. So that's important. It's putting the work into the hands of many, so it's not just one person completing the CGA, it's widespread education so everyone is able to identify the risk and put the appropriate interventions in place.
Great to see lots of interaction from our listeners. We've another few questions there, so keep them all coming in. We've over 60 people online. Now, we do have some other information that we want to share from our speakers here, but we'll just take these 2 questions and then hand over, okay? So Orla Fahy is asking, how many CGAs would you complete on average each day?
Well, I mean, on Monday it could be anything. I know to date we've done GEMS for just a little over 2 years now, and we have completed. We've screened 9,311 people for frailty in 2 years, and 43% of those were positive for frailty, and 65% had CGAs completed. So it can be anything from, like on a Monday, we generally have about 10 to 18 CGAs complete with a team of 3. And then on maybe a Wednesday, you might have 6. So on a general day, you have 5 to 6. And that's a Monday to Friday service.
Yeah, and as an intervention, it again depends on the complexities. It tends to be that someone really complex, they all come in on the same day, and you find the easier ones are another day. So some days you could get 5 done, and other days you might only get 3 done, and it's a really, really busy day to try and get those 3 done.
And then you have to take into account that you have peak times as well. So you're talking about people going to GPs before they come, so our peak times will be between 11 a.m. and 4 p.m. So we kind of are playing a little bit of catch up in the morning from what came in out of hours. And then we know that between 11 a.m. and 4 p.m. we're going to have a higher amount of people that come in at that time. So any day you could have 6 come in together, or you might have none. So it's hard to tell on any day.
But I think it's important not to reflect on the length of time it actually takes. These are really comprehensive. It's not just an assessment, it's all the interventions that go with it. And if you can see one patient and make their journey better for them, it's worth the time that was invested. And it has a knock-on time, say even for that patient, they're going to be in hospital. We know the length of stay is reduced, we know our discharges home improved. We know that they're less likely to come back to hospital if they've had a full assessment like that. So it's not to reflect on the length of time it takes, but it's what we're able to do with that time and the outcome. And even if you can only, if you're in a hospital and you don't do CGAs at the moment, if you could even start doing 1 a day, you're making an improvement in that patient's journey by just doing that 1. And gradually it will build up.
Excellent message there to take. One last question before we move on back to the content. So Orla Fahy again is asking, we have experienced some difficulty turning around patients who may have medical issues. Admission is often done as a precaution. How have you worked around this?
I think a lot of that goes with experience. So in the last 2 years that we've been doing the GEM service, the education, I suppose, around frailty that has gone out has come on in leaps and bounds. It's been huge, and the National Frailty Education Programme has been a huge part of that. And I suppose people are changing their culture around how they admit patients to hospital, yes, we still fall into the category where people are admitted as a precaution, or we still get the social admissions written on referrals, and that's very much a case of educating people that are at the front door with regards to that. And I suppose experienced therapists, nursing staff, that's where that all comes in, because a lot of our information we'll get from nursing staff before we ever go near a patient. So I think it's really important that we provide a very interdisciplinary team, and also that people know that you don't have to be an OT or a physio to complete a CGA. You can be a nurse, you can be a doctor, you can complete a CGA at home with your own person, as long as you know what you're looking for. And I suppose completing it is wonderful, but it's the follow-on effect, I suppose, of what happens afterwards you complete the CGA is what's most important to the person. And I suppose that's kind of where we're going next with this talk as well. So we know, obviously, that early identification is key, and that is followed by a comprehensive geriatric assessment and a quality care plan. And I suppose a lot of our patients in that cohort of people that we see coming in are genuinely sick and need admission and are at an acute stage of illness. And I suppose to follow on with a good care plan, we need to always be thinking about streaming. And so streaming from the acute floor is really important. And having somebody that is a senior decision maker at the front door is vital to any team. So senior decision maker in your NCHDs, your regs, your senior nursing staff, your therapists are all really important at that stage. So it's getting, again, like Nolan said, people to the right place at the right time and being treated by the right person. And so a little bit about being in the right place. Not everybody, needs to be admitted, and some people can go home and they can experience a hospital from home or a discharge to a CEF team, and that's a wonderful thing to be able to provide for somebody, but we don't all have the resources, I suppose, to provide that at this time. And that's something that we are looking at in the future in Kilkenny and Carlow, for instance. So for those patients that need that medical admission and need acute care, what we've done in the last 2 years is that we've provided, one of our wards has changed for a specialised geriatric ward. So we have 12 beds where we stream people from the front door, from our front door team, directly up to there based on some criteria. So one of the biggest things, I suppose, that would be the clinical frailty scale. So we look at people from anywhere from 1 up to 6 on the clinical frailty scale. And the intention, I suppose, of what we're doing with it is that we're hoping to turn people around from the GEMS unit, we call it, quicker, but safer. More importantly, that they're going home with a detailed care plan, a recovery plan, and they're going home safe. And there's always going to be a little bit of risk, and people will get sick and need a longer amount of time. So 20% of our patients that were admitted went to our GEMS unit, and I suppose with regards to the outcomes of that, 86% of those were able to return to their own residence, their pre-admission residence, and only 5% were listed for long-term care. And I suppose that's really important because people are going where they want to, but they're going safer and they're going stronger and healthier. And I suppose that's what's really important, that they're getting the right treatment in the right place. And everybody on that ward is frailty educated, and more and more people in the hospital are becoming frailty educated through the national programme and also in the community. And I think education here is key. And I think going forward, we were discussing earlier that education in the community needs to come outside of the healthcare workers. So people need to understand frailty more, and families and carers need to understand frailty more, that they can identify patterns and they can identify frailty indicators before they even get to their GPs and the hospitals, so they know what's happening and they know what we can provide for them as well. And I suppose then, if you're thinking about streaming and we're looking at people in the ED or the MAUs around the hospital, you know, it's a busy place to be. Sometimes it's a hellfire. you've got walking wounded, crying babies, you've got road traffic accidents coming in, front door, back door, side doors. And if you are experiencing any sort of delirium, cognitive impairment, and you're walking around looking for a toilet or looking for your room, or you don't know where you are and you're afraid to ask somebody, that's when people retreat back to bed and to trolleys and hard plastic chairs, and that's where deconditioning starts. And that's something that we need to be preventing. We need to prevent deconditioning at the very beginning, and that's why we try early mobilization. They get up, get dressed, get moving if patients are able for it. And people become very incontinent because they're afraid to ring the bell to look for the toilet, and they're automatically put into pads. And so that's another thing that we look at through our CGA as well, if people are independent toileting, if they normally wear pads, because very often they're afraid to ask to go to the toilet, or they don't want to interrupt people. And that makes them become very vulnerable. And that's something that we need to be thinking about, and that's a very vital key to play, I suppose, at the front door. And when we're looking at right place, right time, we need to be thinking about the outcomes. So when people are going to the right place for their care, be it a medical admission and a specialised geriatric ward, or to a rehabilitation unit, it does prevent readmission rates. It does prevent long lengths of stay. As you'll see from our own data, the comparisons from 2017 to 18, our median length of stay has gone down a day. Our other hospital admissions and rehab admissions have gone up by 48%, and our readmission rates have come down by 21%. And that's because people are getting the right treatment and the right place for the right people. And as we look at, this is a graph from IEHD. This is 4 Model 3 hospitals from IEHD. And you'll see that the trend for the PET times for people over 75 years of age over 24 hours has come down since May 2018, which is when all the frailty was implemented in those 3 hospitals, 4 hospitals. And it's not a coincidence. As you can see, there is a trend. We've been below the control limit since May 2018. And once you have a trend of, I think, 6 or 7 dots below the control limit, then it's counted. So that's really important. And I suppose then another key aspect that we can think of about streaming then is from the front doors, outside of a ward, and I suppose for the community partners as well to be thinking of, is hospital to home, so discharge to assess teams, which Yvonne will be talking about as well, which is really important because we can provide a certain level of care in people's homes that we are providing in hospitals as well. And I think it's important that we educate the community on what we can provide out there as well. And that's something that we'll be looking at in Carlow Kelly for the future. As well as, I suppose, digitalising what we have at the moment. And another key aspect that we're using in Carlow Kenny for the future is ambulatory unit, which will be run by our candidate ANPs. So again, that's where our nursing staff have come into play as well, with where they'll be senior decision makers. They'll be able to prescribe, and they'll be taking in people from the community, from GPs and public health nurses, so that we capture those people with frailty before they hit crisis point. And just going back then, as I was saying, about the digital aspect. So we are creating a dynamic 365 CRM system at the moment that we'll be piloting for a year to digitalise our CGA, and what we hope to do is improve communication and time, and also it'll give us a little bit more data security and access. So as phase 1, we're hoping to create a digital aspect of our CGA and make it a bit more efficient and cost saving. And then as a phase 2 option, what we're looking at is opening a portal, and that's to link the community and the acute sector together, and hopefully then our ambulatory services and some rapid response and discharge assess will all play a part in that, as well as our case managers that we have, so we're treating the back door as aggressively as the front door. And I suppose it's really important to reduce the length of stays and to increase the same day's discharge. But what we really want is for people to receive a great service no matter where they are, and a gold standard service. And that, I suppose, some people will question whether digital is the way to go and will people understand it. But the growing population is just going to get bigger, and people are getting older, and the people that are coming up are used to smart technology. So I suppose we have to take that into account now before it's too late. So I suppose I'll hand over to Yvonne.
That's great. Thanks a million. Just one more story to tell, and if you can share that from Beaumont.
So, afternoon everyone. My name is Yvonne Reardon, and I'm an occupational therapist currently working in St. Joseph's Day Hospital in Raheny. But I suppose for a number of years I was working in the fit team in Beaumont Hospital as well. I am here today, as Rosh says, to tell a story. It's a patient story as well as a story about a partnership that developed into a discharge to assess model between Beaumont Hospital and our colleagues in the community health area 9 as well. So bringing healthcare home is the title of my story to tell today. And I suppose from what we experienced in FIT and ED is that consistently we were identifying patients who would benefit from therapy at home and a rapid responsive therapy that was provided at home. And not only would they benefit from it, but it was their optimal treatment plan. So in order for that to happen, we needed to think differently and be encouraged to think differently. And I suppose we were very lucky in where we were working that we had an ear with our nursing colleagues, with the consultants, with the whole care of the elderly team, as well as our managers. So we were supported to take that step and to think collaboratively with our community colleagues. So it wasn't a huge team that developed, and it certainly wasn't what we would read about in the NHS, but it was a start, and that was the most important thing, that we were taking the opportunity rather than lamenting what we saw as losing the opportunity for our patients. So we started small, and it was all underpinned by QI methodology again. So the Plan View Study App that you're probably all very familiar with, and that became our language. And it was one whole-time equivalent occupational therapist. So the way that worked on the ground is that it was myself and my colleague Paul Bernard, and we shared it. So we had a 1 week within the FIT team and 1 week outside in the patient's home. So I suppose when you talk about building trust and building partnerships, we're talking about the patients and their family members as well as the community colleagues that we work with. So patients got very familiar with us, and they got to, I suppose we were held to account, because there was a person, if I said, I'll be seeing you at a home next Monday, it was me. I was going to be the one who went home with them. And ultimately, I suppose it wasn't possible to take that leap without the Beaumont Hospital and community colleagues really supporting us, as well as GPs, public health nurses, and case managers within the community as well. So when we sat down and we considered where our referrals would come from, I suppose we had to start with our own strategic plan, and that was a hospital without walls in Beaumont Hospital, and that was trying to avoid an unnecessary discharge and avoid a discharge. So ultimately the aim of this was to make sure that patients got the best care possible as close to home as possible, and they wouldn't spend a night longer in hospital than what was necessary. So thinking of that, we focused on our ED FIT patients, and 64% of the patients that we took home through this project came directly from ED and FIT. And then kind of expanding that, it was the community virtual ward patients. So 17% of our patients were community virtual ward. And that might be a term that everybody's familiar with, but I suppose that was spearheaded by Claire Lewis, who's an advanced nurse practitioner in the CH09 area. And I suppose her virtual ward was seeing those acutely ill, very frail, very vulnerable, very complex patients at home, and supporting other healthcare professionals to keep them and treat those patients at home. So we saw those patients as a step before the front door of ED, and that actually by identifying those patients early, and I suppose trusting Claire and our colleagues that we would respond to those patients to stop an admission from happening. And when we grew in our confidence, I suppose, and grew to understand what we were doing a little bit more, we took the leap to take patients from an early supported discharge point of view, and 16% of our patients came from the comprehensive geriatric ward. So they were patients that would have received a CGA, they would have seen therapy and MDT therapy on ward level, but they were identified as needing that extra bit, so the early supported discharge, in order to facilitate the discharge home. So some of the highlights that I'm going to share with you from that model is, I want to just pause and tell you it was 5 months, that's what we did it for. So it was 53 patients that we successfully got home, facilitated to go back to and stay in their own bed. And if we, we were in a state of testing, so we were constantly analysing our data and tracking and reflecting of how we can do better and understanding the profile of patients that we were bringing out of the hospital. And I suppose it was very telling to kind of consider that the patients, the majority of the patients, sat between the 80 to 89 years of age group. And a further 14% of those sat in the 89 to 94. And then after that, it was 10% of the 43 were on the 95 plus, with one 101-year-old who successfully got home, so we were delighted with that. But these were patients that were incredibly frail, very complex. There's 41% of those patients scoring a 4 out of 5 on the Think Frailty score, which is an NHS score, and it hasn't been discussed here today, but it's just another frailty score. And I suppose 4 out of 5 would indicate that they're the frailest that they can be while living at home. So anybody with a 5 out of 5 will be a nursing home resident. And when we looked at the profile, we understood that 44% of those patients had a cognitive impairment, and we did that using the Ottawa 3DY to understand, like a very simple screen, but they had a cognitive impairment. So 44% of those had a cognitive impairment. And I suppose from the hospital point of view, the whole-time equivalent of an occupational therapist, we did a massive, we were able to save the hospital €740,000. So just looking at how we actually did it is that there was 4 very distinct pathways that developed. And I can just share with you, those 4 pathways can be broken down into the rapid assessment and intervention, rehabilitation, physical compensatory, and cognitive compensatory approaches. And we did that very simply by tracking what we did with each patient. We used a patient tracker. So a patient would come in, we had a tracker set up for them, and what our interventions were, as well as therapy times. So there were patients that we took home, and actually without having that seen, they would have been admitted, but being able to take that step and take them home, do our safety assessments, do our functional assessments at home, maybe hand over and educate the family members. That was all what was needed. We signposted onto the right people, and that was what got their discharge home. And we considered them to be in the rapid assessment intervention. And you can see there that was 2 to 2.5 hours, and that's based on direct as well as indirect input. We also had a patient pathway which was purely rehabilitation. So they represented 8 hours of therapist time. Again, that's direct and indirect units, so potentially 6 encounters. So there was a scale as well. Some might be 4, some might be 6, based on what we can do. And ultimately, with the rehabilitation pathway, we didn't have a troop of people going out. We were educating family members. We were educating the carers that were coming in programs, home exercise programs, ways of working. And again, the ethos of educating around frailty and that getting up, getting dressed, getting moving, the importance of that and keeping yourself well. So there was a trend of self-management within the frailty scope as well. That was really important for family members and the patients as well to take on.
I think a nice point to link in with this from Alice Gormley, one of the participants online. She's just saying about how recently she spent a number of hours in her local ED, and it was a great opportunity to observe what goes on re the management of frail patients. Many people spent hours in ED with no access to food and were fearful of going to the toilet in case their name was called and they would be missed or left for longer. I was astounded by the fact that I never heard one mention of primary care services, and there was no info re local primary care services and how to access them. So this is exactly what you're talking about, Yvonne, linking people in straight away, and that integration between acute and primary care is so important for these patients.
So important, and I suppose to understand, it can be complex for us to understand what's out there. And often I was involved in speed networking events last year, and to actually, it was quite overwhelming to understand that how many stakeholders are involved in the care of the older person at home. And that, how much of it I didn't realise, and I would have thought that I would have been somebody that was quite informed. So for a patient at home or a family member, it is really difficult to navigate. And I suppose one of the aims or working aim would have been, we need to help people to navigate this system. It is really complex. Sometimes it feels very broken, and that sometimes we need to be the people who are amplifying the voice of the patients in these scenarios. So moving back to the pathways, there was physical compensatory strategies, both for people who had a fracture mostly, and we were working with them as well as the carers so that they could function at home rather than having to be placed in a rehab ward or placed in a ward awaiting rehab, as well as cognitive compensatory patients as well. And they would have been quite a number of hours from a therapy point of view because of the repetitive practice and nature of those patients' needs as well. And I suppose following on from that, I just want to share one particular story with you of a lady who came from home and presented to ED with the urinary incontinence and acute confusion. Family were incredibly concerned, and luckily we had our specialist geriatric ward available, so she was screened appropriately by the FIT team. She got to the specialist geriatric ward, and you know, she had a very thorough, very comprehensive assessment and treatment plan that was put in place, and she medically recovered. She was well enough. She was medically optimized and appropriate for discharge. However, our fears, and I suppose as an inpatient therapist as well as family members, all you saw was vulnerability. And certainly for somebody who is coming out of a delirium, who might have an evolving dementia or a known dementia, you know, you see the risk when somebody's in hospital. And it was only with the discharge to assess team or this pilot program that we were able to trial home. And equally, that wasn't a decision that was ever made without Mary herself or her family. It was very much in line with what their wishes were and how much they wanted to do whatever they could so that she could have the best quality of life and enjoy the last remaining days of her life. So I'd love to discuss that a little bit more, but I think our time is nearly up. So I suppose when it comes to discharge to assess, it's more than just meeting the needs of ED and avoiding admissions. It is the quality piece, allowing a person to live well and their best life in the place that they want to live. And just from my personal experience, I suppose it was a real privilege to be allowed to take on that role and take on that journey with patients. Working in somebody's home instead of the ward, you often see their strengths in their home, while we can be quite impairment-focused around the ward. I suppose it was empowering to design a service and to work with people in a collaborative way and work with our colleagues in the community and to see things a little bit differently. And I'm proud to have been part of that partnership for sure. Yes, there was difficulties, there was challenges, there was ups and there was downs, but I think being allowed that space to reflect was incredibly important, and it's something that stood to me in my current role in St. Joseph's as well in the day hospital setting. So that's it.
Okay, thanks a million. Just to say thanks to everybody online. There's been great interaction with all of our listeners online. There was over 60 people from around the country tuned in to us today. Just before Alison rounds up, I'd just like to thank our speakers for sharing your invaluable experience with everybody online. I think we've had a lovely, I suppose, depiction of that journey from ED right through into the community and how all of you in your different ways have made that journey better for those frail patients. So I'm sure people are listening online buzzing with ideas to go off and try in their own services. So just to hand over to Alison to finish up, and thank you so much again for taking the time to share with us.
Thanks, Rosh. I guess a couple of points I wanted to highlight. Listening to you, Yvonne, describing what can be achieved when we wrap a team around our patients at home, it really emphasises the point that capacity is not about beds. Capacity is about how we use the resources that we have. And I'm recalling Dr. Cunningham from St. James's, who's, of course, a member of the brilliant Home First team there, describes these front door and acute floor teams as the secret weapon, I suppose, as we're really in earnest progressing through what we know we need to do better with in terms of care for our patients, so to launch your care. So just leaving us with that thought that capacity can be increased by recycling. We talked about this in the last session, by recycling the funds that we're currently using to grow our teams to be able to multiply the impacts that we've heard today, because we've heard some tremendous leaders today who had very little to work with, but they had leadership and they had obviously the support back in place. This doesn't happen independently. It happens with the multidisciplinary team support. And interestingly, in some of the cases, they had a service improvement team stepping the local team through the change process, which we need to give a lot of thought to that, because where that's happening, really good outcomes are being realised quickly. So I think it's just, these are considerations in terms of success factors that we need nationally to spend time thinking about and replicating where it's working.
Just to pick up on that, Alison, sorry you're in a train of thought there, but it's just a nice comment here from one of our listeners about Yvonne, really about your test, and just asking, was there any plans basically to roll that out nationally, and that there's good outcomes there from that? So he said, are there plans to mainstream the test project following its success? And in terms of awareness and education of the person receiving care and their families, has any consideration been given to raising awareness for home care workers, etc., to identify issues that may arise?
I'm just going to mention a little bit on behalf of the Integrated Care Programme for Older People, who really recognise that discharge to assess is a very important component of this end-to-end pathway, and they're very keen to progress the development of this aspect of the overall older person service. There's so much scope, I guess it's worth us acknowledging, in terms of discharge to assess. We know that in the UK, for example, there are terrific results coming from using home care staff differently, thinking about reablement and home health being a dual function for one person who works in the person's home, but is crossing acute and primary care boundaries. So what we're seeing is that there's true enablement possible by approaching it in this way, re-enablement possible, and that it's very cost effective for services because we're reducing therapy time. It's really good for patients who say to us they don't want loads of people coming into their homes, so they want people they can build trusting relationships with, and those people therefore need to be developed to have a wider skill set, and we need to do it efficiently because there are too few practicing people in the country to be able to meet demand. So we've endless scope in terms of making this service available to our patients, and it definitely is another key step forward in the Integrated Care Programme for Older People's plan. But just to finally finish, in each case today and last time, we were hearing about small opportunities that were grabbed. And so just a final, I suppose, suggestion for us all is not to wait until things are perfect, because they're rarely perfect as we view perfect. In fact, we don't know what we need until we get going on the journey, which is QI in its essence. So it's encouraging people to just take one step, take one step and see where it leads.
That's a nice point to finish on, Alison, but I'm going to squeeze in one final question. Do your FIT teams have access to faster home care packages? I would imagine not, no. So it doesn't make a difference to that.
We hospital teams have better access to community. Sorry. So my understanding is that hospital-based teams, and especially when you can advocate to say this is going to avoid a admission, that they will be given more preference. And I suppose that's when you get quite skilled at understanding the whole scope of the hospital and the care of the elderly, and that connections with your social care head really in the community. But certainly as it stands, you know, hospital patients rather than community patients are given more access to home care packages, new home care packages.
And that's actually a message that it's important for family members and that to realise there should be better access from home as well, because the last time you wanted patients being admitted to hospital for a home care package, it should be equal. It should be based on the patient's need, irrespective of their location. Now our links have developed strongly with the PHN liaison, who would flag if someone requires home help, and because of that, the patient is being identified much earlier. So that identification is leading to earlier home care packages, but as such, they're not ring-fenced for the 15th.
And I think the other thing we're taking into account now as well is that some people need services for an interim period, for a recovery period, and that's something that we're looking into down south as well, is because when somebody presents to the hospital and they're in an acute phase, and we assess them at that point, and at that point they need their care, but in 6 weeks' time they may not, and they may have become more independent and are doing those things for themselves. And I think it's very important, we're working with our community partners at this stage to prescribe services correctly as well. So if it is something that is being used for a recovery period, that we inform the liaison officers or the public health nurses that this is what we're looking for at the time of when the person is in the hospital, because they can then review them quicker. Because they're also, they're stretched, they've got a huge amount of areas to cover, especially in the rural parts of Ireland. So, I mean, that's really important. So it's really important at an acute level that we're prescribing these properly.
Just very finally, it goes back to the point that we mentioned last week, that money can be used differently, and every solution starts with a local innovation, one step to testing. If there's something to this that can improve care, so we really are encouraging that be taken on by those who are feeling that there's opportunity locally for them. Recycling money to use it differently means there's easier access to home care, and we do need to look after our home care staff in a different way. We need to look at their being paid mileage to travel, etc. Those kinds of things that are barriers for them at the moment. Very finally, just reiterating what we said last week, that the National Health and Social Care Professions Office is working with the Quality Improvement Division at the moment, designing what we're calling a collaborative, so building a national network for people like the leaders we have here in the room and had the last time, who are actually developing services locally, with a view to supporting them to develop, and for frontline staff to be designing what standard practices should look like, what competencies, what workforce configuration will have the best impact for patients and their outcomes. So we'll be in touch over the next 2 months, expressing interest in how we're going to seek involvement from frontline staff. So we'll be in touch with an expression of interest process, and we really hope there'll be huge uptake. I think it's together, that co-design approach in terms of how these services can be made better and better and consistent, so that every patient attending every Model 3, every Model 4 hospital gets an excellent service. That's been so apparent in the room today. That's what everybody is working to achieve.
Thank you so much, Alison, and thanks so much to everybody online, and again to our wonderful speakers here today. I think this is a topic that we could give a number of webinars to. We're only just scratching the surface, so thank you so much. Just want to direct people online to our National Quality Improvement Team Strategic Plan, which is up online, and we'd welcome anyone's comments or suggestions or feedback on that with the link that is there. And the next webinar is on Tuesday, which is the wrong date. It's actually April 2nd, sorry, the date is wrong there, and it's going to be on person-centeredness, making a difference in practice, which I think picks up nicely from this, because essentially, look, that's what we're all about, is trying to wrap our care around what the person wants themselves. So we'll finish on that, and thanks so much for all your interaction, and see you then at our next webinar, the first Tuesday in April. Thank you.